liver abscess, PLA. Definition and overview. A pyogenic liver abscess, PLA, is characterized by a collection of pus within the liver tissue, primarily caused by bacterial infections. Historically, treatment involved open surgical drainage. However, advancements in medical technology have shifted the management approach towards less invasive methods. Currently, the standard treatment combines targeted antibiotic therapy with image-guided percutaneous drainage, which has significantly improved patient survival rates and reduced morbidity associated with the condition. Etiology and causes. The pathways through which infections reach the liver have evolved over time. The primary causes of PLA include biliary tract disease, now recognized as the most common cause, especially due to obstructions caused by gallstones, strictures, or malignancies, such as cholangiocarcinoma. Instrumentation procedures like stent placement or biliary drainage are significant risk factors. Portal vein spread, infections originating from intra-abdominal sources, such as diverticulitis or appendicitis, can spread via the portal vein to the liver. Hepatic artery spread, hematogenous dissemination from bloodstream infections, including endocarditis, can lead to abscess formation. Direct extension, adjacent infected organs, such as the gallbladder, can directly extend infection into the liver. Direct trauma, injuries, surgical procedures, or local treatments like radiofrequency ablation, especially in patients with prior bilioenteric anastomosis, can introduce infection directly into hepatic tissue. Cryptogenic cases. A significant percentage of cases have no identifiable source, classified as cryptogenic. Epidemiology. The incidence of PLA is increasing globally, although it remains a relatively rare condition. It predominantly affects males and older populations. Key risk factors include diabetes mellitus, significantly elevates the risk of developing PLA. Biliary disease, obstructions and infections of the biliary system. Malignancies, particularly those affecting the biliary tract. Immunosuppression, conditions or treatments that weaken immune defenses. Chronic kidney disease, associated with increased susceptibility to infections. Clinical presentation. Patients with PLA typically present with a combination of systemic and localized symptoms. Symptoms: fever, chills, right upper quadrant abdominal pain, malaise, and nausea. Signs: jaundice may be seen, especially in cases related to biliary obstruction. Complications: potential for rupture into the peritoneal cavity, leading to peritonitis or metastatic septic infections such as endophthalmitis. Diagnostic approach. Diagnosis involves laboratory tests and imaging studies. Laboratory tests: leukocytosis and elevated inflammatory markers like CRP. Elevated liver enzymes, particularly alkaline phosphatase. Imaging modalities. Ultrasound, U.S. often the first imaging modality, revealing hypoechoic lesions. Computed tomography, CT the gold standard with approximately 97% sensitivity, showing hypodense lesions with rim enhancement, known as the target sign. Magnetic resonance imaging, MRI useful for detailed biliary anatomy assessment when biliary causes are suspected. Microbiology. The causative organisms vary geographically. Asia, Klebsiella pneumoniae, especially serotype K1, is predominant, notably in diabetic patients with cryptogenic abscesses. Western countries, Escherichia coli and Streptococcus milleri are more frequently identified. Polymicrobial and anaerobic infections are common, particularly with biliary or gastrointestinal origins. Treatment strategies. The primary treatment involves a combination of antibiotics and drainage procedures. Antibiotic therapy. Empirical broad-spectrum intravenous antibiotics are initiated promptly, typically including third-generation cephalosporins combined with metronidazole. Therapy is later tailored based on culture results, with a prolonged course often lasting 4 to 6 weeks. Drainage procedures. Percutaneous catheter drainage, PCD, the first-line intervention for abscess drainage, especially effective for larger or complex abscesses. Percutaneous needle aspiration, PNA, suitable for small. Surgical intervention. Reserved for cases where percutaneous methods fail, abscess rupture occurs, or underlying surgical pathology needs correction. Surgical options include abscess drainage via laparotomy or liver resection, particularly in cases involving hepatolithiasis or extensive parenchymal destruction. Prognosis and outcomes. Modern management has significantly reduced mortality rates to approximately 6 to 20%. Factors associated with poor prognosis include underlying malignancy, liver cirrhosis, septic shock, gas-forming abscesses, hypoalbuminemia, renal failure. Infections caused by Klebsiella pneumoniae tend to have lower mortality despite their association with metastatic complications owing to advances in early detection and targeted therapy. Chapter